So men treated with focal therapy can experience focal failure 1/3 of the time. And as I explained yesterday, half of these failures are either outside the ablation zone or in the ablation zone. So yesterday I addressed failures outside of the ablation zone, and that's mainly due to lack of identification of clinically significant cancer because current technology, i.e. MRI, while good at identifying the primary or index lesion, doesn't often identify the small satellite lesions. While brachytherapy is an attractive means of focal ablation, the dose required to eliminate cancer is not fully understood. So this gets back, again, to what I said yesterday. Regardless of the energy we're using to ablate the area where we think the cancer is located, that energy has to be able to demonstrate that it can fully eradicate the tumor. So in terms of radiation therapy, in order to determine the true ablative dose, we investigated different dose levels and compared these to post-implant positive biopsy rates. We then in turn investigated in a prostate model the use of rectal spacing to limit the exposure of the organs at risk to focal irradiation, which, when you think about it, can be applied to other technologies. So when you look at focal therapy for localized prostate cancer with either high-intensity focused ultrasound or cryoablation, and this is a single institution experience, and just look down here at the in-field recurrences, and these are biopsy in-field recurrences. In this particular study, with HIFU or cryo, the local recurrence rate in the ablation zone was 33%. So you ask the question as to why it's so high. Is it just maybe the margin, or did the freeze or the heat not deliver enough energy to eradicate the disease? So when we turn to brachytherapy, we have a lot of long-term information because when we set up the program at Mount Sinai in 1990, since I was the surgeon involved with this, I made it a mission to determine how much radiation we needed to deliver to the prostate to eradicate all local disease. And in my mind, back in those days, of course, if you were using PSA in 1990 and you were given radiation therapy, it was PSA of 4. Well, if you hit PSA of 4, it was a success. And then it was PSA of 2, and then it was Astro, and then it was Phoenix. So you never really got to the point where, like a radical prostatectomy where the PSA is less than 0.2 or 0, that you had a degree of confidence that you actually cured the patient locally of the disease. So we started on this mission of doing 2-year post-treatment biopsies, and I recruited of my patients 545 men who agreed to have a biopsy out of our patient population. So at 2 years, if the biopsy was negative and the PSA remained 0, we didn't repeat the biopsy. If the biopsy was positive, it got repeated. Biopsy got done for those who were negative, and then they developed a rising PSA. They got a biopsy too. And lastly, for men who had sort of an intermediate biopsy, so it wasn't frank cancer, but it wasn't completely negative, if those men's PSA became 0 over time, not Phoenix definition negative, but actually 0, then those men were considered to have a negative biopsy, and those biopsies were not repeated. And then we converted the radiation doses to the biological effective dose. The reason that we did that was because men were getting iodine implants, men were getting palladium implants, men were getting combination therapy. So we needed a common denominator so we compare results with one dose description rather than looking at different types of doses that would be used for the different types of radiation energies applied. So the median age was 65, the median PSA was mean PSA was 10.5. You could see it about 44.8% were low risk, and the rest were either intermediate or high risk. The median BED was 178. Now, what's interesting when you do this type of study, for those centers that started brachytherapy programs much later, there's a much smaller range of doses. But the range of doses delivered in our patients was as low as 15 and as high as 282. And you would ask the question, why is that range so large? Well, the reason the range was so large is because when we started in 1990, we basically started from scratch. And since I was trained in Memorial during the day of the retropubic implant, and so were my other colleagues in radiation therapy, we just took the Memorial tie line nomogram and we applied it to what we did. Fortunately for us, we had written our own house post-implant dosimetry program, so we could always check after every implant. But it took us almost 3 years to get up to a dose level that we felt confident was consistent. But during that period of time, we created an inadvertent dose response study. And that's the reason why we have this information that we can now look at and say, okay, what dose is right? Centers that started later where the doses were more consistent never had the opportunity to look at it this way. So we took advantage of our basically lack of knowledge about what to do to take a look at what's the right thing to do. So in terms of the implant, there were 52.7% had implant alone, 31% had hormonal therapy, and 16.3% had hormones, external beam, and seeds, and those were typically the high-risk patients. And so the time from the end of therapy to the last biopsy was a mean of 6.7 years. So these are not short-term biopsies. These are really late biopsies. And the follow-up of these patients is a median of 11.4 years. And at the end of all these analyses, the positive biopsy rate was 6.2%, which is pretty low, but it's still, you'd like to be zero. So how can you get it to be zero? And that's really what we're talking about. So we put together these dose cut points. And on the left, you see the BED dose, and on the right, and this is an important thing to consider, are the extrapolated doses if you were giving an iodine 125 implant or you were delivering external beam radiation. So if for men that received a BED of less than or equal to 140 gray, and that would be equal to an implant of 134, which is not far from ABS recommendations, or external beam of 73.8 gray, those men had a positive biopsy rate of 17.9%, which is very high. And you can see it transcends across risk categories from 14.3% for the low-risk patients and all the way up to 20% for the higher-risk patients. And as you go up in dose cut points, you can see there's a continuous drop in positive biopsy rates. So you get up to around 200 gray, where the men who receive more than 200 gray, the positive biopsy rate now falls to 1.6%. And when you get to 220 gray, there were no positive biopsies in the intermediate and high-risk patients. But look what the doses you have to deliver to get up this point. If you're doing an iodine implant, it's 189 gray, which is substantially higher than the recommendations. And if you're delivering external beam gray, and this is 1.8 gray fractions, you got to get up to 106 gray. And if you really want to get up to a dose that's totally ablative for the intermediate and high-risk patients, you've got to do a BED of 206 or an external beam radiation therapy of 115. So I don't think most people, I'm pretty sure that most people are not typically delivering these high doses, but if you're contemplating focal therapy, you don't want to be up here because you're going to be just like the cryotherapy and HIFU therapy we have today where the infield recurrence rates are too high. And when you do a regression analysis influencing biopsy results, you can see that the BED is highly significant in the multiple regression. What's the consequences of leaving prostate cancer behind? So this is not necessarily translatable to all therapies, but if it's radiation therapy, and this is 20-year data now on cause-specific survival, you could see that men who have a positive biopsy have a far inferior cancer-specific survival than those men who have a negative biopsy. And that translates into an 8.4-year mean year loss of life. So when we talk about doing focal therapy and we have about a 30%, 25 to 30% positive biopsy rate either in field or out of field. And if that's not addressed, long-term consequences could be significant. And these curves really don't start separating substantially till you get out to 10 to 15 years. So the early biopsy data, just like everything else we do, early data, when you're comparing arms of studies, they don't really start to diverge substantially till you get out with long enough follow-up. Again, the positive biopsy rate was highly significant in the Cox regression. So these are high doses. How do we protect the rectum? And we've had a lot of talks yesterday about using a space OAR or Barrigel to protect the rectum when patients are getting radiation therapy. This study from Memorial, Mike Zalewski's group, shows you can see the little black dots on the MRI, the radioactive seeds, and the use of a spacer. This is for normal full brachytherapy treatment. However, there are consequences using these devices, these spacing devices, and what Zalewski reported in his study, while there was definitely a reduction in rectal doses, so we typically look at the volume of the rectum, which is called the rectal V100, covered by 100% of the dose. And we always like to see that less than a cc, maybe less than half a cc. So you can see in the spacer cohort, it was 0.01 cc's. But in the non-spacer cohort, it was 0.07. Now, 0.07 is pretty low. So we're talking about an experienced brachytherapy team, and you can ask the question, well, do they even need rectal spacing because they're so good at protecting the rectum because they know where to put the seeds? That may not be true in centers that are not as experienced. It's probably not as true. That's why there's more rectal morbidity. So the benefit may not be so great in this situation. Now at Memorial, the planning dose is the ABS recommendations is 145 gray. That doesn't mean they deliver it 145 gray. They probably deliver more. So what do they deliver? So in this study, there's a D90, and it was the spacer cohort received 112% of the D90, which the planning D90 is 145. So that puts it around 165, 170. So it is higher, but it's not near as high as what we said. Remember, the BED, to get a BED of a 200 gray, you need an iodine implant with a D90 of 189. So it's still less, but nonetheless, they're doing a great job in terms of sparing the rectum. So you would ask the question, why do they need a spacer? Especially when you looked at the risks of other problems. And in this group, 13.5% of the men developed urinary retention if they had a spacer. So there are consequences because, you put a lot of fluid in, you push the prostate up towards the bladder, you've got a swollen prostate after the radiation. The two of those together could cause problems, and they essentially did with regarding urinary morbidity. That went away, but it's still not comfortable for the patients to have to wear a catheter. There's not a lot of data on the use of spacer sculpting or limited spacer use, but there's this one study from Pinakawa where they were treating men with focal brachytherapy for recurrent prostate cancer, and they used this iodinated spacer here. You can see it's just laid in around the area where they put the radioactive seeds. So there have been a couple of reports of doing this clinically. So we decided, a group I got together, which is Dr. Ben Van Este, who's a radiation oncologist in Belgium. Basile Skouteris is a urologist in Athens, Greece, who worked with Richard and I for a year as a fellow before we went back and started a brachytherapy program there. Dr. Campos Pinheiro is a urologist I trained in Portugal, and then I got together a group of people to perform this investigation at Higia Hospital in Athens. And we used prostate phantoms, which were provided by VMRS. Bard provided us loose and stranded dummy seeds. Varian provided the intraoperative dosimetry equipment. Palette Life Sciences provided the Barrigel. And we did these implants in the OR, simulating what you would do in a patient. And we had either one region of interest, and we did one posterior lobe, or we did both posterior quadrants, as I described yesterday. This was presented at ESTRO last year. So the intention was to perform an implant with a target dose D90 of 207 gray, replicating what I just showed you for the biopsy results. And the phantoms were implanted in the OR. They were then taken to the CT scanner, and we did a CT scan so we could do post-implant dosimetry on the phantoms. We brought the phantoms back to the OR, put them in the exact same position, and then using the variant program under dosimetric and ultrasound guidance, we placed the spacer in the area where we believe the doses were high based on the intraoperative dosimetry. Then we took the phantoms back to the scanner and we rescanned them to see what the changes are. And then the post-implant dosimetry was done in 3 different institutions, Higia, at Dr. Van Este's institution in Belgium, and one group of were done at Mount Sinai. So the results showed when we had defined the area to be treated, the clinical treatment volume varied based on whether it was a 1 lobe or 1 quadrant or 2, between 5 and 15 cc's with a mean of 8 cc's. The percent of the focal volume to the whole prostate varied between 17 and 38% with a mean of 25%. Makes sense, it's about a quarter of the prostate. The total number of needles necessary to implant the focal volume ranged between 7 and 10 with a mean of 9. The total number of Cs with an activity between 0.5 and 0.6 millicuries varied between 27 to 41 with a mean of 33. To put this into perspective for those who don't do implants, permanent seed implants, typical implant we put in between 70 and 100 Cs depending on the size of the prostate. So it's about 35 to 40% of the seeds you would normally use to do an entire gland. Now, the mean focal D90 to the clinical treatment volume was 227 gray. And the D90 for the entire prostate gland was 60 gray. So we were able to achieve our target doses without over-irradiating the entire prostate. In fact, remember the typical D90 of an entire gland that for a patient that we do at Mount Sinai with an iodine implant is about 189 grays. So it was less than a third of a full implant. And there were no different. The other important thing to notice is there was no differences between whether you did a stranded focal implant or you used a MIG applicator. So they gave the exact same results, which is good because throughout the country, there are surgeons who prefer, or radiation oncologists who prefer to use stranded seeds, and others who prefer to use loose seeds in a MIG applicator. So what happened when we placed the spacer on average? There were 12.5 millimeter separation between the prostate and the rectum with a range of 11 to 14 millimeters. The mean dose to 1 cc of the rectum with and without the spacer was reduced from without the spacer 40.2% to 24.4%. And the mean dose to 2 cc's of rectum was reduced from 33.8% to 24.9%. So here's what it looked like. This is a post-implant dosimetry CT scan of the prostate with implantation of just the left lower quarter of the gland. As I discussed yesterday, that is the most common place, other than both lower quadrants, for prostate cancer to exist if you're considering focal ablation. So you can see the seeds are very close to the capsule, and you can see how the dose comes out. These are different 3 millimeter slices. And so the D90 to the gross tumor volume was 210 gray. And here's the post-implant CT of the same phantom, now with the Barrigel or the spacer inserted. You see it over here in yellow. And you can see it's all on one side because it was placed only where the activity was placed. And you can see also how the rectum and the prostate are separated nicely by this approximately extra 1 centimeter. And it didn't really affect at all the dose of the prostate because the D90 to the gross tumor volume was still 210 gray. And that area in here is a clinical treatment volume. That's where the region of interest was. One of the interesting things about giving radiation therapy is and different than other therapies, is when you're in the OR, you can see live we call these the isodose contours, around your target, so you can confirm, at least intraoperatively with ultrasound, that you've put in enough activity to achieve the goal of getting the dose you want. And that is represented here very well. So the next type of case we implanted was both posterior quadrants of the prostate having prostate cancer, which I said yesterday is the most common. So you can see here, again, the dose to this whole posterior quadrant, it was 230 gray, whereas the dose to the entire prostate was only 95 gray. And this is pre-spacer, and this is with the spacer right now. So now you're putting in more spacer because you've got to deal with both posterior lobes. And the dose to the prostate went up just a tiny bit, 97.9%, but the dose to the tumor volume didn't change at 230 gray. So in conclusion, focal brachytherapy can be highly successful if the D90 to the tumor volume is approximately 220 gray. A dose this high can eradicate 99% of Gleason grade 2 to 5 disease. Transperineal mapping biopsy demonstrated that men who are candidates for partial gland ablation most frequently have disease in the posterior of the gland, and the use of our spacer should reduce risk of radiation injury to the rectum. A sculpted placement directed at the areas of high posterior dose has the potential to reduce some of the morbidity associated with full spacer insertion. Thank you.